evening, everyone. My name is Mo. I'm an interventional cardiology fellow here at UVA, and today I'm just going to present a case of a gentleman that came into our hospital a while ago with a STEMI that was complicated by development of cardiogenic shock and ischemic MR. So we'll see. We'll just go over his hospital course. Um, so basically, he's a 57-year-old gentleman with history of remote stroke that was back in 2011, PE, hyperlipidemia, pre-diabetes. He initially presented to our hospital back on March 14th, a while ago. He had a 3 days course of chest pain that was intermittent, and then it started becoming more intense and constant on the day of the presentation. You see
Mo,
here.
I
Mhm.
am so sorry. Can you switch your screen? We're looking at the presenter view.
Oh, okay. Let me see. Display setting. How about now?
Yes, perfect. Good.
Here you
I learned
go.
something new. Thank you.
Cool. All right. That's better. All right. So, if you look at his vital signs and physical exam, you see he's a bit hypoxic on room air was setting 88% and also congested as well. But blood pressure initially was okay, 123 over 79, but definitely having basal crackles and tachypneic. So that was his EKG on presentation, and as you can tell, there is definitely an ST segment elevation, especially more in the lateral leads in one AVL and also in AVR. So upon this EKG, the STEMI pager went off, and the cath lab team was activated for STEMI here. So we took him emergently to the cath lab, and basically, going over the pictures here on the left, you start seeing the RCA, and basically, there is no evidence of significant disease on the right coronary artery. But once we started engaging the left, you can see here in the middle shot that there is 100% thrombotic occlusion in his left main. And you start seeing here on the right picture that we started wiring the left main and started ballooning to basically establish flow. And upon ballooning the left main, he actually went to pulseless VTAC and ended up getting defibrillated twice. We brought him back post-resuscitation map, who was down to the 60s, of course, started getting more hypotensive, emergently started him on pressors with epi and nor-epi. And we decided to emergently place an Impella CP for more hemodynamic support given the ongoing cardiogenic shock presentation that has been evolving during his STEMI. And basically, we placed the Impella CP. That definitely helped started getting more stable and being able to proceed with the PCI more. So you see here in the top left, we redirected the wire into the LED, also wired the circ into the OM. We followed the DK, decided to go for a DK crush stenting of distal left main bifurcation. So after wiring the circ, we ballooned the circ, and you see on the bottom left here, actually, we deployed the stent from the proximal circ back into the left main. And on the bottom right here, there was a balloon that was stationed in the LED that used to crush the circ stent. And then going all through the steps, we rewired again in the circ here. We did the first kissing balloon inflation, as you can see here on the top right. And then we deployed the stent here, as you can see in the LED, back to the left main, rewired again into the circ, and then we did the second kissing balloon inflation in the distal bifurcation. And after a pod or a proximal optimization technique by optimizing the stent in the main, that was the final outcome that we got with the flow, both in the left main into the LED and the circ with a TIMI3 flow at the end. Um, so again, after the presentation or at this point, he was still on NOR epi at 16, still at epi at 4. He required an Impella support at P7. So of course we went ahead and started getting right heart cath to check his invasive pressures and hemodynamics. And as you can tell by looking at the numbers here, significantly elevated filling pressures on the right side and the left side with a wedge of 30. Definitely significantly reduced cardiac output and index down to 1.7. His CPO was 0.7. Also, we checked the lactic acid in the lab, and it was elevated at 4.1. On a side note, given also the ongoing hypoxia, he ended up getting intubated in the cath lab as well. And at the end of the case, cardiogenic shock team was activated to basically gather all the stakeholders to discuss his presentation after we were able to stabilize him in the lab. And after basically a multidisciplinary discussion, the decision was, given his extremist status, to admit him to the CCU, continue the current support with the Impella and all the ongoing pressors, and watching him over the next few hours in the CCU and deciding how going to be his progression and if any there should be any need for further escalation of MCS for him. So he got admitted to the unit, continued on pressors. Over the next 24, 48 hours, there have been trials to wean his Impella, including here the pictures from the very first echocardiogram that he got while he was on our CCU. And as you can see here in the apical four chamber, significantly reduced EF down to 25, 30%. In the middle shot here, you basically in the short axis, you see the hypokinesis more severe and more, significant in the anterior and lateral wall. The inferior wall is slightly doing better. And at the beginning, just focusing on the mitral valve here, you see a degree of MR. It's not terrible, but just mild MR. Eventually, actually, over the next course of the following 3, 4 days, he started showing some gradual improvement in his oxygenation and his hemodynamics, which prompted the team to end up taking the decision to extubate him. So he was extubated on day 5, but unfortunately, within 1 or 2 hours after extubation, he started getting really hypoxic again with nausea and vomiting and ended up getting intubated again. So right after he got intubated, the team noticed significant increase in his mean PA pressure, and his wedge actually and his PA diastolic were up to the 30s, and they noticed significantly elevated V waves on the wedge tracing. As a part of the workup, they ended up getting a transthoracic echocardiogram first, which showed definitely a progression of his prior MR from mild into now moderate to severe. So they decided to get a TEE on him as well for further evaluation of the MR. And here I'm including some pictures of his TEE. And as you can see here on the bottom left, that there is a wide open MR, definitely severe, just by looking at the color Doppler here. And on the ONFOS 3D view right in the middle here, you can basically see that the source of MR is coming from the tethering and the limited mobility of the posterior leaflet, and which also creates the direction of the MR jet more central to be posteriorly directed, which is absolutely consistent with the ischemic MR presentation. And with the measurements that you can see here, they were all consistent with severe MR, whether with his EROA or the vena contracta of 0.7 or the regurgitant volume exceeding 50 mLs. So right after he got his TEE, up until that stage, it's almost been more than a week since his initial presentation. So initially, the decision was that we need to swap his Impella CP with an Impella 5.5, which was done on day 8 from his hospitalization. Up until that point, after he got reintubated again, he briefly was on pressors. His lactic acid was initially pumped up again after the hypoxic episode, but then got normalized. And then all the stakeholders again came back together to the table to decide, including the CCU, heart failure team, cardiac surgery, interventional slash structural valve team. And the decision was eventually basically to proceed with a transcatheter edge-to-edge repair, trying to fix his moderate to severe MR, which right now primarily is responsible for the worsening in his hemodynamic status and clinical status. So he eventually ended up getting transcatheter edge-to-edge repair using the Pascal device. And basically here, including all the steps of the procedure that was done almost about 4 weeks since his hospitalization. So in the top left, you basically see the initial or the baseline picture with the severe MR. Then following this, in the middle top row here, you see the transeptal puncture and then grasping the anterior leaflet, and then the bileaflet grasp on the bottom left, and deploying the clip here. And eventually on the bottom right, you see that only mild residual MR was left there after the clip was released, with basically significant reduction in the MR intensity and successful restoration of flow across the mitral valve. And even here, that there was eventually, after the clip was deployed, there is no evidence of significant mitral stenosis. The mean gradient across the mitral valve is pretty low, about 3. And just including here a picture of his baseline hemodynamics at the beginning of the procedure and at the bottom at the end of the procedure, and you can appreciate that there is definitely an improvement of his mean left atrial pressure from 15 down to 12, and also the V wave and also the PA pressures, and also an improvement in his PA sat from 64 getting increased up to 70%. So there is definitely an improvement in his hemodynamics that came with the mitral clip. Eventually, the patient got extubated. He successfully came off the pressors, and then while he stayed in the CCU, the team started actively working on weaning him off the Impella and trying to introduce lower doses of GDNT. But unfortunately, despite multiple attempts, they were unable to take him or wean him totally off the Impella, given recurrent episodes of hypotension and VT that he kept having. So the heart failure team started getting active and listed him for heart transplant, and the decision was basically to go forward with the listing for an orthotopic heart transplant for him. He continued on the axillary Impella 5.5 support, and to regain his physical strength and get him ready for transplant, he started working daily with physical therapy, ambulating, walking around the unit every day. And finally, he actually ended up getting his new heart a few days ago on June 6th. And I'm here including the pictures from the very first echocardiogram of his transplanted heart that was obtained a couple days ago. And you see here in the parasternal long axis and also in the apical fourth chamber, a very good squeeze from the LV and RV function with an EF estimated to be 55 to 60%. So he's also doing well right now in the cardiac surgery ICU. He is totally off inotropes, off pressors, scheduled to have his first right heart cath with biopsy next Monday. And that's all what I have. And thank you all for listening.
Thank you so much for that presentation, Mo. And so, Mo was Dr. Eltelbany's was intimately involved in taking care of this patient. It's a little bit different than, what we usually see with STEMI shock, in that the goal for most patients, of course, is native heart recovery. But despite everyone's best efforts, including that of the patient participating in PT, we couldn't recover his heart, and so he had to go on to heart transplantation. But of course, now he's doing well.
Excellent. Thank you, Dr. Etebani. Um,
Sure.
Open the floor up. Are there any questions or comments about the case?
Oh, hey, it's Mike Contos. I may have missed it. The etiology for the mitral regurg, that a posteriorly directed
Yeah,
restricted leaflet.
yeah. Well, I think it's mostly was the ischemic MR. It was primarily coming from the tethering of the posterior leaflet. If I go back here to the TEE, the very first TEE pictures, um, there was no evidence of any rupture in the pap muscles or any rupture of the cords. So here I'm trying to include the ONFAS 3D view. I think this one here was showing how much the posterior leaflet was tethered there, and even the direction of the jet was more kind of like central to be posteriorly directed, which was already consistent with how the ischemic MR just kind of like got progressed from his presentation.
From annular dilatation from the ischemia, or do you think he was just getting acutely ischemic and getting MR on top of that?
I think it's more was coming from the ischemia itself. I don't think it was getting more ischemic. Probably it was just more about the remodeling of the LV and more about the wall motion abnormalities that was primarily responsible for the change in the annulus and especially more in the infralateral wall. And this is what kind of like was responsible for the progression of his MR in the first place.
Yeah, I agree. Unfortunately, his wall motion abnormalities never recovered. He basically took out his entire LAD and circ territory, and so I think the posterior medial pap muscle suffered as a consequence.
We had I'm trying to remember a somewhat similar case a few months ago in which a patient had a very large infarct went on Impella support, came off, and got acutely ischemic, much like, at least it seemed to be ischemic when things were weaned. You would see the V wave get much bigger. And what we ended up doing was she was being pumped at that point. We actually did a TE, and then we would turn the balloon pump off with the TE in place, and you could see the MR get dramatically larger to the degree it became much more severe. It was an interesting demonstration of how well that Impella actually works for ischemic MR as far as unloading. We've had a couple of those where we'll do the, it's very hard to do it without the ET. When they're unstable like that, you have to have some support, but it's useful to wean down the support while you actually have the probe in to see what's happening once you remove that support. And it was fairly quick that the amount of MR would increase. It only took a few seconds for the MR to kind of suddenly dramatically go up, and then it took a little bit longer for it to go back down once we turned the pump back on.
Yeah, I think it's pretty much like the turnover that happened in his clinical course, because things apparently were initially heading in the right direction and going well, and that's what kind of like, as I mentioned, triggered the team to extubate him. But within a couple hours, I think with the afterload surge, despite being on Impella and his Impella support at that point, I believe it was between P6 to P7. So it wasn't like absolutely weaned down significantly, because basically they wanted to make sure that he's hemodynamically supported on the Impella for the extubation event. But despite the Impella support, again, he had that significant hypoxia event and ended up getting reintubated again, and never figured out the reason until they saw the surge in his PA pressures, and they eventually figured out the worsening in the MR situation.
It's a good illustration of why you should look at the tracings rather than just rely simply on the numbers that you see, that you get
Correct.
reported.
Yeah.
Dr. Eltelbany and Dr. Patel, I congratulate you really for saving this patient's life. This is a remarkable, really a remarkable case. And we all speak about cardiogenic shock. And when we take care of these patients, we all realize how sick and how quickly these patients can just deteriorate. And the spiral of shock is real, especially in those kinds of circumstances. And the fact that you already had the swans and you were prepared and imaging, so it's a very collaborative work that ultimately, with the decision making rightly on time and step by step, with a wonderful outcome. I really congratulate you all for this. And this is really, this forum is for us all to share these experiences we learn from each other. And we round and we get these patients. For whatever reason, the last 1 week I was on CCU, and thank God I just came off an hour ago. Probably we had the busiest service over the last few years, over the last 1 week, than any time before, from acute MIs with all kinds sorts of acute MI with cardiogenic shock in all flavors. But one important element of this is, as Dr. Contos really nicely mentioned, about the relying on the waveforms and not the numbers. And it becomes like a practice that a lot of times in the cath labs, they just report the numbers, even the waveforms don't even make it. And especially when you are at the bedside, you do this, or in the cath lab, the look of the waveforms and correlating what you see and what you do with what you have, a lot of times things just doesn't make sense. And it reminded me one of my cases that I did several years back. I was at WVU, and I transferred a patient from Elkins with acute inferior ST elevation MI, and patient was given TNK and transferred to us, and I was in the cath lab receiving him. We got him there, and he had a large RCA. Of course, I was the culprit, and he did have some flow back with the TNK, but nonetheless, I could not stabilize the patient. So we put an Impella device and went up with a swan. Despite the Impella device, I could not stabilize the patient. And then we went up with the swan, and the first thing that I got from the swan was the PA SAT, and it was about 90. So put a pigtail next to the Impella, big, large VSD. Even though you don't suspect that, I mean, This was given TNK, timely presentation. We are still within the first few hours, but those mechanical complications can still happen, or whether it's an MR from mitral involvement or it's a mechanical complication. But I think a timely waveform, SWAN, echocardiogram, TEE, all can be very adding to each other to make final conclusions and subsequent treatments. Wonderful case.
Yeah, it's definitely the combination between the invasive hemodynamic evaluation and the imaging in this one, especially with his decompensation, because they tried to figure out what's the reason behind that quick decompensation in the first place. And they started looking back over the course of the preceding few days, and because things were heading in the right direction. And then all of a sudden they are seeing this happening again. So I think the echo came in pretty handy and confirmed what was seen on the invasive hemodynamic tracings. So always speaks up for the importance of the using different modalities to reach to the correct diagnosis there.
Dr. Kontos, with echocardiogram, I know we have excellent echo labs, especially in the hospitals, proliferating with a lot of echo techs and newer machines and a lot of good detailed imaging. But I feel our fellows are just not as good as we would like them to be. And I think the clinical practice shifting, sonographers doing everything, and just people completely relying on the reports or maybe reading, not as good as acquiring images. So I don't know if this is something that when I was on the CCU service, we always would like to get our own images, and especially acute MIs, prioritizing imaging in those cases, changing in the clinical status, re-image them. I don't know, somehow I feel our training is just not as robust in echo to rely on the fellows and cardiologists in training to be able to acquire their own images. What do you think about that?
I think we've seen that a lot recently. We've always had a program in which we really try to encourage our fellows to do it and actually require them to get their 150 echoes that they do that they're required to meet their level 2 training. I think we took a big hit during COVID where many of our fellows were out for a while doing virtual type stuff, and that made a hit. What we've noticed in our CCU too is that I think we've gotten so busy that the fellows are managing patients and they don't have time to do the echoes. We used to require them to do every echo in the KICU. This was way back when. Now we try to encourage them to do at least, they've got 3 or 4, just pick 1 or 2, pick the easy window to do to get the practice. And someone who trained in echo, I feel your pain greatly. We frequently mention to the fellows, it seems like everyone in the world is doing ultrasound except cardiology fellows.
Except cardiology, exactly. That's what I said during our recent rounds. We have an ER physician that he was actually better than our own echo to acquire good images.
So I think it's something we need to really focus on, because I think once, and particularly in these cases, there are subtleties that are important, particularly in a sick patient with cardiogenic shock, and it's very easy to miss it unless you think about it. For example, this case with MR, the secret is that you have to look at the Doppler, not just the color that we rely on. With VSDs, I think I try to make the point to our fellows that a stethoscope is still one of the most useful tools, because you can usually hear the VSD, but it's easy to miss on the echo if you're not looking in the right place. And so I think it requires, much like this case, index of suspicion. My first thought would be, if the patient was decompensated, they're having recurrent ischemia, rush them to the cath lab, make sure they've suffered stent thrombosis. But it's important to think of those other complications that may lead to the patient decompensating. MR in this case, or in another case, a late presenting VSD, which may pop up. So we had a patient a few years ago who received lytics, and he actually developed tamponade, an effusion in tamponade. So it took a while to kind of figure it out, because the effusion wasn't big. We put a balloon pump in him. His blood pressure looked great. He had a 40 millimeter augmentation, which everyone would think would be awesome, but his lactate kept going up. So finally we ended up having to drain it. But again, that was a fairly rare complication to occur, but keeping an open mind that it's not purely ischemia when they decompensate or worsening heart failure from the LV dysfunction. I think this is a good case that illustrates that you looking at all the information again to make sure you're not missing something can make a big difference.
Absolutely. So on the same lines, actually, this Friday we had because we are advocating our thrombolytic pathways, and we had one of our probably farthest points. A patient wife brought him because he asked for her help. He said, "I just don't feel right. Something is wrong." He couldn't identify himself, but finally he said maybe some discomfort in the upper arms, maybe around the neck, and so she brought him and dropped him in the ED. And by the time she parked her car and came back and was trying to talk to him, and suddenly he collapsed on her. But that was in the emergency room. So she called for help and they found him in VFib. They shocked him. They took him to ER. And the ER doctor evaluated him, did an EKG, had anterior ST elevation. So the first thing he did, he reached out to us to transfer the patient. And while he was on the phone with me, he said, well, he's gonna have he has another VFib, so I have to rescue him. So he shocked him again. And then, of course, we looked into the EKG, big anterior ST elevation MI. So his transfer time, and by then, patient has already walked up. He said it's about 3 hours from us. So we both made the decision. I think it was patient did not have any contraindication for thrombolytics, to consider the thrombolytics, considering this recurrent VFib. So he did give him TNK, and actually 10 minutes later, he sent me the new EKG completely normalized, and patient became normotensive and good. So patient was transferred to us en route. While before reaching us, the patient became hypotensive. So upon arrival, we evaluated him. Of course, his EKG was better. He was by then already intubated. So considering the hypotension, he was on 30 of norepinephrine. I took him to the cath lab, did the angiogram. Culprit was LAD. Basically, you did have some flow, maybe TIMI2 with 99% ruptured plaque. And I fixed the LAD, but the fact that he was on 30 of norepinephrine, and it's a big LAD with no pre-existing disease. So I said, the first thing, let's put the SWAN as we advocate for it. So we did the SWAN. RA pressure was 2, and wedge pressure was 8 or 9, and PA-SAT was good, and the index was 2.5. So kind of scratching our head, this is an acute MI, what is going on? So we gave him volume, and we're looking our access site, at our SWAN site, everything. We don't see any bleeding from anywhere, yet the numbers from the SWAN does not consistent with a cardiogenic shock. So just to make it short, we had to give him 4 or 5 further fluid boluses over the next few hours, like from midnight until like 4 a.m. Until around 4 a.m., he vomited blood. So the SWAN was very helpful to differentiate. This was really hypovolemic shock, and we were very kind of vigilance about any potential bleed, drop in the H&H. So we saw that, we thought, oh, maybe we know what it is. But things keep deteriorating, and the H keep dropping despite our volume support. We tried not to transfuse him. Now it's actively bleeding. We already placed the stent in the LAD. It was a huge challenge, but nonetheless, I keep getting SWAN numbers. The SWAN numbers after cardiac index is maintained, cardiac output is maintained, yet the shock is still not well managed and controlled, and lactate was increasing, creatinine went up. So finally, and I didn't want to expose him to contrast, but at the outside hospital, they gave him contrast for throughout P. I don't know why they did that. There was absolutely no need for it. And I gave him contrast for his cath. I didn't want to do another contrast image. Anyway, did a non-contrast CT, a large intra-abdominal bleed, intraperitoneal, not even retroperitoneal, not even around the access site, intraperitoneal bleeding. So again, so we had to do supportive care, of course, and tried to avoid transfusion, but ultimately we ended up giving 4 units because he actually went under 7 and did a CTA, no active bleeder. Ultimately, things just tamponaded itself. I think the bleeding held and H&H improved, and we were able, thank God, to give him aspirin and Plavix after holding it for like 2 days with a fresh stent. The point that I'm making, we did an echocardiogram, LV function maintained, so things just didn't add up. You have an LV function that's maintained, early revascularization, yet the patient was in shock. So until we found all of this, it took several hours, almost to 24 hours. But the SWAN was so helpful and the echo was so helpful to give us the support that we needed to look for other reasons, be vigilant, see where the potential etiology might be. So just I found it to be very interesting. These things happen whether it's a late complication, it's a bleeding complication, it's a true cardiogenic shock from the acute MI, but we can sort it out with the collaborative work with our own imaging, of course, and SWAN and active hemodynamic monitoring, surveillance of the patient clinically.
Yeah, your point is a really excellent one, Dr. Bazinci. We recently had a patient who presented with a STEMI and arrested in our emergency department, and the ER team got ROSC pretty quickly, but she got about 15 minutes of CPR. We took her to the cath lab, stabilized her initially, got TIMI-3 flow back in the vessel, and then about 6 to 8 hours later, she started to decompensate in the cardiac ICU, and she had developed a massive left hemothorax, probably as a consequence of the CPR that she received. But it took good bedside clinical acumen to understand why she was becoming more hypoxic and hypotensive at the same time.
Excellent cases. Well, thank you, Dr. Patel and Dr. Talbani for sharing this wonderful case with us. And anybody else in the group has any questions, any comments?